The best way to use a pelvic binder is indiscriminate application to any patient with blunt trauma and hemodynamic instability, and that includes simple tachycardia. We don't spend a lot of time thinking about pelvic binders, but they are a critical piece of equipment in major trauma, and I really think that we are doing this wrong. The traditional approach is that you get the patient with blunt trauma, they've got some hemodynamic instability, somebody rocks the pelvis, and then they say, oh, it's unstable, let's put on a pelvic binder. The truth is that nobody should ever rock a pelvis. If the patient has a pelvic injury, every time that you squeeze that pelvis, you're dislodging clot, you're gonna increase bleeding, and you're also increasing pain for the patient. Instead, we should just empirically apply the binder, get an x-ray, and determine whether the patient actually has a pelvic fracture or not. It's great to talk about strategy, but we do have to hit on some logistics. The way that I like to do this is to have the pelvic binder on my gurney before the patient comes in, and then transfer the patient off of the EMS stretcher without the longboard directly onto that pelvic binder. Once the clothes are cut off, I'm going to apply that binder immediately to reduce the potential fracture and to tamponade that bleeding. That's going to cut down time from the patient's arrival to getting the binder on and getting that fracture reduced. The most important thing to remember in all of this is indiscriminate application of a pelvic binder in blunt trauma patients with any hemodynamic instability.